I'd like to start by introducing our lecturer. This is Dr. Gerard. She's an assistant professor and licensed psychologist within the Division of Child and Adolescent Psychiatry at the University of Maryland School of Medicine. She has extensive experience in providing direct clinical care, supervision, and training. Dr. Gerard specializes in conducting psychological evaluations, particularly for autism spectrum disorder, infant and early childhood mental health, and pediatric integrated behavioral health. She serves as the director of the Maryland Psychological Assessment and Consultation Center, which provides psychological evaluations for children aged 14 months to 18 years. In this role, she supervises psychology externs, doctoral interns, and postdoctoral fellows. Um, I just want to put in a plug. I've had an opportunity to work with her and train with her in fellowship. She was one of our supervisors, and I think everyone here is very fortunate to have an hour of lecture and get to learn from all her experience and expertise. So we're all very excited. That being said, I'll have Dr. Gerard share her screen and kind of take it over from here.
Thanks, Dr. Akbar. What a nice welcome. And I see quite a few familiar names. Um, so it's good to see you all on here. All right, let me go ahead and share my screen so we can get started. Those of you that have heard me talk, you know that this is one of my favorite topics. So I will try very hard to stick to the timeline. Here we go. Okay, this all looks good on your end? Yeah, okay. All right, so I'm going to talk about some assessment strategies and then treatment considerations for autistic children and adolescents. So some of the things that we'll talk about or look at are the core features and developmental presentations of autism. I know you all are familiar with the DSM criteria, but just talking more nuanced, what we sometimes see that may not be as obvious as some of the more stereotypical symptoms of autism. And then how to differentiate autism and other commonly overlapping psychiatric conditions or neurodevelopmental disorders and then some specific assessment measures and tools, as well as, once we give the diagnosis of autism, what do we do with these kids? So, certain referrals and recommendations that are often appropriate for young children, school age children up through adolescence. All right. So, as you all know, there's two core symptom categories for autism. There's social communication deficits that combine the language piece as well as the social components. And then that category of restricted interests, repetitive behaviors, and activities. Um, and then some of the other pieces that make up the diagnostic criteria include onset of symptoms in early development. Really, I have this slide here just to highlight that one component as we're assessing kids as they get older and move into adolescence. Having that early developmental picture can be really helpful, especially when we're looking at individuals that are more on that level one end of the spectrum, so lower support needs. To be able to tease apart, is it autism or is there maybe something else going on that where the symptoms maybe showed up a little bit later. And then, of course, as for most diagnoses, causing significant impairment in social, academic, and or occupational functioning, and not better explained by a global developmental delay or intellectual disability, though, as you all know, they often co-occur. So when we look at that first symptom criteria, um, it's made up of the social emotional reciprocity piece. So things like being able to engage in back and forth conversation, being able to pick up on like conversational cues, nonverbal communicative behavior. So not only are we able to, functionally speak and engage in that social back and forth, but are we able to do it while also coordinating eye contact, using gestures appropriately, using directed facial expressions? When I go over results with families, I often say, the reason we look at these things is not because autistic kids can't do these things, but sometimes they have a hard time integrating them. Like they may have a nice range of facial expressions, but they're being directed at whatever toy they're playing with or whatever item they're engaged in, and not using it to share that enjoyment with whoever they're with in that moment. And then also that piece of being able to develop and maintain social relationships. So sometimes kids may just not show much interest in interacting with peers or having friendships, but oftentimes, and again, really on that level, well, even on the level one end of the spectrum, we see both, where they may have a really strong interest in developing friendships, but they just struggle to do so in a way that's appropriate or being able to understand why they have a much harder time making friends than other same age peers. So sometimes this can be a hard piece of the criteria of like, well, they're so friendly and they want to have friends and they want to talk to others, but if they're still struggling to do so, that can certainly be a sign of autism. And then conversely, there are also kids that I've worked with where they really don't even understand why you would ever want to interact with another individual unless you have a need that needs to be met. Like if you want to have a job in a certain field, you would obviously have to go through an interview, or like being able to speak to people in positions of authority. But other than that, if it doesn't benefit them in some way, there's really no intrinsic like social drive to interact with others. So again, huge spectrum of what we can expect to see. Um, some of these pieces, I wanted to um, go over some questions that often come up when we're looking at these diagnostic criteria specifically. So let's see here. When we're looking at differentiating autism and anxiety, like social anxiety, that can be challenging. Um, because it makes sense that if we struggle with social interactions, we might be more anxious, or we might come off as kind of socially awkward or quirky if we're socially anxious. So some things to consider, of course, is there a presence of restricted interest and repetitive behaviors? Is there something else that's going on for the child that may be causing some challenges with engaging in back and forth conversation? Like, is there some kind of language delay, or does this child have a history of stuttering and has become really anxious to interact with peers because they've been teased or are self-conscious about, you know, how they're presenting to peers? And so those are also underlying factors to really think through of, are there social deficits related to anxiety? Or are they related to a true deficit in understanding social interactions, picking up on cues, and things like that? Another thing that often comes up is when children do a really good job with those peer relationships, or at least that motivation to have friends. They are social, but they struggle more so with those nonverbal communicative behaviors. And trying to then tease apart, why are they only meeting maybe two of three of the criteria in this section? And if they don't meet the full criteria, can we say that they have autism? So something here that I often will look at and consider is the child potentially masking? Are they working harder than their other same age peers to be able to engage with other children in a more appropriate way? Do we see this like autistic burnout at the end of the day where they've really struggled to keep it all together throughout the day? And something else to consider as well is when they maybe perform well in the office with you. So they can engage in back and forth conversation. They're social. They're interested in talking to you. So some things to keep in mind in those situations is how though do they interact then with people their own age. You know, if they have an IQ, a high IQ or high verbal capacity, you know, and they may be able to relate to an adult really nicely. But when it comes to peers, if they're still talking like that, it's likely that they're struggling to connect with peers on the same level. They may not have the same interests as their same age peers. And sometimes as adults, we tend to help facilitate in social interactions, you know, fill in things for the child or, you know, help that get them through a social interaction, whereas peers are not going to be quite as accommodating. So it's really important to get collateral from, you know, what are the teachers seeing in school? What are the parents seeing, you know, when they're out on the playground or wherever in other interactions? Because just because they might be doing really well with you on a one-on-one setting, it may look very different in other social situations. So just some things to consider when we look at that first set of criteria. And then here, the second piece, restricted and repetitive behaviors. So to meet criteria, having to evidence two or more of the following. So this can be some of those repetitive and stereotype movements and use of objects. So repetitively, like uh, flipping items in their hands or, you know, kind of those hand flapping, spinning, rocking, repetitive pacing, but then also speech here. So engaging in scripting, you know, word for word from videos or television shows. Sometimes the scripting can be functional and they actually pick lines that fit perfectly in the conversation, but it's very clear that it's not their own language and it's coming from somewhere else. Sometimes even that's hard to pick up on if it comes off as very context appropriate, and you may need caregiver input of like, oh, they're repeating lines from, you know, whatever show. Sometimes it's not so obvious when we may not be up to date into, you know, all the different videos and things that kids are interested in. But also just being very inflexible. So wanting to follow a certain routine, wanting things a certain way, that also falls into this category. That's less obvious, perhaps, you know, wanting to do things the same way every day, you know, always having to have the blue plate with the blue cup and sit in the same seat. And if anything is out of the norm, that can cause a huge meltdown. Also having restricted interests, so you know, getting focused on certain topics. It's pretty obvious when the topics are sort of unique, but it can also be things that are popular for, you know, other kids of the same age, and that's when it can also be a little bit harder to tease apart. And we tend to see that more with girls, where it may be more of like a socially appropriate interest, but it's just a bit more above and beyond. But you know, we see it with like vehicles and trains. I've worked with a kid who's really interested in air conditioning units and would ask like what brand everyone had. And I have no idea what brand of AC unit I have in my house, but that was his thing. He really liked to talk about it and look for them and ask questions and tell you about his. So lots of fun. I've had lots of fun conversations and learned so much about very unique topics over the years. And then there's also the sensory piece. So this can be either being sensitive to things, so more sensory aversive, avoiding loud sounds, avoiding certain textures, like textures of clothing, things that are too tight or too loose, too scratchy, certain materials. Seams in the socks. Now, most clothing don't really have tags, but if there are tags in the clothing, that can be bothersome. Being sensitive to bright lights or just like flashing lights and things. Smell can also be one. So sometimes kids have a really hard time, like in the school cafeteria, because all of the different smells are just really overwhelming. Um, and then also taste, the picky eating, avoiding certain textures of food. So that's something I always ask when I'm gathering background information. Um, and then there's also the sensory seeking behavior. So maybe having a preference for certain textures, liking to have like always having a certain like blanket or something that they like to rub. Or sometimes parents will say like, my child is always like rubbing my ears or my hair or, things like that. So some of that sensory seeking. That can also be visual, abnormal visual regard. So sometimes you'll see kids like looking at things out of the corner of their eye. They'll do that either like when they're spinning in circles or they'll like lay down and watch their like cars drive by or just like having items kind of going through that line of vision for them. Um, so something that commonly comes up especially when we're looking at these criteria for autism is how do we distinguish between more like just odd, quirky, awkward kids who struggle with socializing and those that actually have autism. Um, and the biggest pieces to look at are, is it because they have, very high IQs, very high verbal skills, um, and maybe don't have the RRBs that go with it? Sometimes we'll see that. There's also a lot of overlap again with that social anxiety. We want to take a look at ADHD also being a neurodevelopmental disorder. And, oh, there's that tornado warning. Um, and or some of these symptoms more so related to possible trauma. So again, getting a really good history to make sure that we're ruling out any trauma symptoms better explaining it. Um, when there is a lot of overlapping symptoms or not quite meeting criteria, that is also maybe a good time to refer for a full psychological evaluation to even, further tease apart any other sources for their presentation. Another piece that sometimes comes up is like, man, they're really awkward. They have these challenges with communication or nonverbal communication, but they're not quite meeting in the area of RRBs. Can we still give a diagnosis of autism? And the short answer is no, but keeping in mind that the RRBs do include that rigidity, the sensory sensitivities and interests, and stereotype language. But if they're still really not meeting in the RRB category, I would strongly suggest considering like a social pragmatic communication disorder, which is basically autism without the criteria B, without those RRBs. Um, and there can certainly be other things like anxiety that would present similarly too. So really needing to tease apart the criteria, but the social pragmatic communication disorder really encompasses that category A without that category B piece. Okay, so now I'll go into finishing up the diagnostic criteria. We already talked about these. Again, just really making sure we have a good understanding of early development and the symptoms are happening in two or more settings. So, we need to see that these symptoms are happening at home and school. If it's only happening in school, let's look at maybe more anxiety or maybe ADHD or other things that might be going on. And then we'll look at the specifiers here. So when diagnosing autism, it's not just yes or no to autism. There's also a lot of other things that go after the diagnosis. So the first being the level, which I have backwards here. I'll get into that on the next slide. But we also want to identify if there's also accompanying intellectual impairment and or language impairment. So when I do psychological evaluations, we'll always do some kind of cognitive measure to determine if there's also an intellectual impairment. So, and this can also help inform the level of autism that the child has. And then I'll also give this separate, if they're 5 years or older, give an intellectual developmental disorder diagnosis, or if they're under 5, a global developmental delay, if they meet criteria cognitively, and then I'll also give an adaptive measure to be able to make that diagnosis, as well as background information and history. And then also, if there are any known genetic or medical conditions that we know are often associated with autism, I'll note that in the diagnosis. And of course, just some of these other pieces if there's any additional mental or behavior problem or catatonia. And then the 3 levels of autism. This is something that often takes the most explaining to caregivers and parents when giving the diagnosis. They're often familiar with what autism is, but not necessarily the levels or how many there are. So I always explain to families there are 3 levels of autism. We really try to use language that comes from an area of, the level of support they need versus a level of impairment. So level 1 requires the least amount of support. This I'll often tell parents, like if they're looking at like Googling things or looking at older research, likely they're going to see more similarities with the term Asperger's versus autism, since historically autism were kids that required more intensive supports. And then level 3 requiring the most support. So these are kids that often have significant language and cognitive deficits. Usually I'll hold off on diagnosing really young children with level 3 autism, since they're still in that growing and development phase. So we want to take advantage of early intervention services, and we're not quite able to give like an intellectual developmental disorder diagnosis yet. So often I'll put those kids that are showing a lot of signs of autism when they're young at a level 2. And as they get older, then really teasing apart across the three levels. Another important thing to consider, and I mentioned this briefly already, is camouflaging or masking behaviors. This is something that we tend to see a lot in females. But even in males, and definitely more so in that level 1 autism category. So essentially, when an autistic child is engaging in masking or camouflaging, they're really trying to compensate for any autism related challenges or difficulties that they have in social situations. So they may use more scripts, or they may copy other people that they see. And so then that requires really carefully observing other people, because things that those of us that don't have autism, it may come a little more naturally. They're really having to study and pay attention to what these individuals are doing. And then masking one's autistic characteristics by constantly monitoring their own behavior. So not only are they watching what everyone else is doing to try to copy it, then they have to monitor themselves. Am I making enough eye contact? Is it too much eye contact now? How are my facial expressions? Are they matching the situation that's going on around me? Are my gestures making sense? And so really trying to present as non-autistic in front of others. And then assimilation. So behavioral techniques used to better fit in with other individuals. So like basically performing, pretending, forcing themselves to interact with others to present as less autistic. And then not surprising, when you're doing all of these things all day long, it can very quickly lead to autistic burnout. And this is that an intense mental state that can just cause physical exhaustion and loss of skills needed to manage daily life. So parents may say, like, well, they're doing okay in school. They hold it together all day, and then they come home and it's just a mess. Well, yeah, they've been working really hard all day. And something that we'll also see in kids that get diagnosed later, or others around them may not pick up on those signs of autism earlier on. And that can be because a child can maybe mask or compensate up to a certain point, but then their capacities are tapped out and they no longer can meet the social demands. So, when kids start using sarcasm and there's just a lot more abstract, nuanced social interactions and things, that's when it's really much harder to keep up. Whereas when kids are younger, things are more concrete. It's okay to be a little silly and quirky and funny. Whereas when you get older, you would expect some of these behaviors maybe to reduce. Um, and, even older adults, it may more so become a diagnosis that's sought out once things just totally fall apart in relationships, work environments, things like that, where they've been able to hold it together for so long, but now it's become too much. All right, so switching gears into assessment. One of the things I really want to highlight is the assessment requirements per Maryland Medicaid. As you all are familiar with, a lot of what we do gets dictated by what insurance will cover, and we have to kind of mold into some of those requirements. And so these are what is required to be included in the documentation that then would allow for a child to get like ABA therapy services covered. So one is to complete a diagnostic evaluation by a qualified healthcare professional. This includes pediatricians, nurse practitioners, psychologists, psychiatrists, neurologists, developmental pediatricians, regular pediatricians. So all of those, obviously with appropriate experience, can be considered qualified healthcare professionals. And hopefully my power doesn't go out while we're talking. And then there are also some components of the evaluation itself that are required. So some sort of direct observation or interaction with the patient is super important. You have to actually see the child in action. And I will say, over the years, when I've evaluated parents that have come from various other types of providers and receive the diagnosis, and sometimes the feedback they give is they barely spent any time with my kid. They don't know them. How can they say my kid is autistic if, they didn't even play with them or interact with them? They just talked to me for an hour and gave the diagnosis. So that's not the only reason why it's important, but it is important to take time to get to know the child and observe them. And this can be done through standardized diagnostic measures, like we see in number 3 here, like using the ADOS, the CARS, or some kind of screening measure that's more observational in nature or in a less standardized format. Getting that really in-depth developmental and psychosocial history. Were there any language delays? If they're not currently engaging in any RRBs, did they as a child, were they walking on their tiptoes, spinning in circles, flapping their hands? Maybe they've learned to adapt or some of those behaviors have reduced over time. Also documentation of their current presentation across major domains of development. So, how are they presenting now in these various different social, emotional, behavioral areas? But also, of course, how has that kind of progressed since early childhood? And then this is kind of obvious, but you have to actually state in the document that they met criteria for an autism spectrum disorder. It has to have your signature on it. And it also, there has to be an ABA referral dated within the past 6 months. So when I do a full comprehensive evaluation, I make sure my signature is on there, my qualifications are on there. The diagnosis is very clearly there. I indicate that ABA therapy is medically necessary for the child. Carolyn really likes to see that it's medically necessary. and make sure that all of those pieces are kind of in the first page or two so they're not flipping through, and then the rest of the great wonderful resource and referrals are there, but just so that the family, they've already had to wait so long and go jump through so many hoops. The last thing we want is just for insurance to not be able to find the information they need on the referral. um, so a little bit more regarding diagnostic evaluations. Not only do we want to get that good developmental history from caregivers and other important people in the child's life, we also want to make sure to get, the understanding of how a child presents across settings. If they're in school, teacher forms, are also really important to get. Sometimes we know parents sometimes will underreport or overreport symptoms. So just the more data and information we have, the better. Once a child's old enough, self-report measures are also really helpful. Even if the insight isn't super great, sometimes that's also just good data to know that, like, wow, their insight is not so great because we're seeing all these concerns and they're denying all of it. But sometimes they have great insight, and it's very helpful in that regard as well. And another piece that isn't required, per Carelon or Medicaid for diagnoses, but I feel is very important, is to rule out other explanations for why the child is presenting the way they are. It's very easy to fall into this confirmation bias of, oh, someone mentioned autism, it could be autism. I think it's autism. Let's do some autism screeners and then we're going to diagnose autism. Well, did we look at the whole range? Could it actually be better explained by ADHD? Is there a trauma history that's been present that has impacted development and social communication skills? Are there other behavior disorders or anxiety that better explain it? So always coming in with an open mind, and just because, they may meet the checklist of diagnostic criteria, really, our role as mental health professionals is, determining the context behind the behaviors. Why are they presenting the way that they are? So I'm going to go through a few autism screeners that can be helpful. All of these are free access. All of these are linked to the various websites where they're coming from. So I'm sure you'll receive all of these resources, and they'll go through the various age ranges. So I tried to give you things that'll cover across the board of childhood and adolescence. So any of you all that work with young children, maybe even if you haven't, are familiar with the MCHAT for our youngest of young patients. So the MCHAT can be given from 16 months to 30 months of age. Really quick, easy 20 questions. If any of the items are endorsed, there's a follow-up component where you can ask more in-depth questions to determine whether or not a child passes or fails that item. Two or more fails indicate that the child needs further assessment for autism. For ages 5 through 12, there is this modified questionnaire for autism spectrum conditions. So similarly, looking at the various different symptom categories for autism, but it does cover a bit of an older age range. And then the RBQ, or the repetitive behavior questionnaires, can be completed across the age range by caregivers, but there's also a self-report version for children ages 13 and up. And this looks more specifically, not surprising given the name of the measure, but those restricted and repetitive behaviors. But it also includes like the rituals, wanting to follow certain routines, the repetitive motor movement, sensory, repetitive actions with objects. And then we have the autism spectrum quotient, the AQ. There are 3 different versions that span across the age range. So there's the caregiver report for kids ages 4 to 11. There's adolescent caregiver report for 12, for 12 to 15-year-olds, and then the adult version is 16 years and up. And this looks at social interactions, communication patterns, imagination, which isn't something that necessarily goes into the diagnostic criteria of autism, but it's something that we often look at because we see that autistic children have a harder time engaging in creative play, using items in ways they weren't intended, being more abstract in that regard. So it's helpful data. It also looks at attention to detail, tolerance for change. And this one can be filled out and actually scored online, so you don't have to hand score it, it'll do it for you. Um, this next one is a good one to really tease apart those camouflaging traits. Really for any older adolescents through adulthood, but especially when we see those, females that are even more likely to camouflage. So this measure starts at age 16, goes through late adulthood, and just really specifically looks at camouflaging behaviors. And then there's also the RADS that starts at age 16. And this is for that more level one category of autism or even subclinical autism. It's a self-report measure and looks at a variety of different areas, including language, social relatedness, sensory motor concerns, and circumscribed interests. So again, all of these are free online and can be helpful tools in addition to doing a thorough background history. I mean, there are also a lot of great screeners that can be purchased and used, but these are a nice place to start and some really good screeners that you don't have to pay extra for. Okay, so I want to spend a little bit of time talking about differential diagnoses, and really what we want to consider when we're teasing apart some of these diagnoses that have overlapping symptoms. So first, some of the big overlapping ones, and for those of you that have worked with me before, you know that I love to talk about the how trauma symptoms can look like a whole lot of diagnoses. So not surprising, I'll start with that. Um, so this, hopefully you can see it okay, really goes into not only the differences between autism and ADHD and trauma, but where the symptoms overlap. So in ADHD and autism, we would expect to see some of those impulsive behaviors, difficulty concentrating. In ADHD, that looks more like trouble staying focused, getting easily distracted by things in the room. What we'll see with autism can look a bit more like being in their own world, having a harder time, being pulled out of whatever they're doing to focus on what, for example, at school, the rest of the class is working on, or the inattention is maybe more related to the restricted interests. I'm thinking of a kid that I recently tested who restricted interest was in vehicles, but more so the sounds, and but only became distracted when outside there was like a semi truck driving by and then having to talk about, that's definitely a semi truck. I've been in a semi truck before, and that's absolutely the sound that it makes, and then was able to refocus. So it wasn't just like everything was bothering him, it was just very specific sounds of certain vehicles. Risk taking, restlessness, intense emotions, all of those can overlap. I do want to take a second to talk about those intense emotions because oftentimes in training, I'll have students that will add that in as part of the diagnostic criteria, or the reason why they're giving a diagnosis of autism is because of emotion dysregulation or behavior challenges, and having to remind students that that's actually not part of the diagnostic criteria for autism or ADHD. But it is something that often happens and co-occurs because, not surprisingly, if you're overstimulated, there's too many sensory things happening in your environment, or you are not able to functionally communicate your needs, your wants, your pain, it makes sense that you're going to act out and engage in behaviors. And similar with ADHD, sensory overload is also very common in ADHD, and just becoming easily overwhelmed if there are too many things and directions being thrown at you and you're not able to keep up. Um, that can lead to those intense emotions or impulsively responding to situations and things like that. So, while very commonly co-occur, I wouldn't make a separate, behavior diagnosis based on that. And I also wouldn't say that all kids with ADHD and autism have behavioral or an additional symptom because of these diagnoses. And then when it comes to trauma, excuse me. We know some of those main symptoms of intrusive memories, avoidance of triggers, hyperarousal that obviously often looks like inattention in ADHD, flashbacks, sleep problems, emotional numbing. But again, those overlapping with autism specifically are those intense emotions, difficulty feeling safe, the sensory pieces, which can have, kind of a maybe lead to flashbacks or other, memories of the traumatic event. So social withdrawal can overlap in, so again, kind of looking at why is this child not interacting with others? Is it related to trauma or is it related to autism and either less interest in peers or struggling to engage appropriately, so just choosing not to? Rigid thinking, needing to have that control when the rest of your life feels out of control from the trauma end, and shutdowns, becoming overwhelmed or dissociating with trauma, sensory overload, transitions, things not going as expected, very in autism, very easily leading to shutdowns. Um, and then here, more specifically looking at social anxiety and autism and that overlap, since this is a big one that often comes up, especially when we're looking at level 1 autism. The overlap in terms of having anxiety in social situations. Again, there are those autistic individuals that don't have anxiety in social situations because they're not so worried about what other people think of them and they're just happy doing their thing. But there are also so many that are anxious because they know that they're struggling. They just don't know how to change it. In social anxiety, there's obviously the anxiety of having to interact with others, maybe more of a performance anxiety or worried that they're going to say something stupid or look stupid or something like that. Both can obviously have challenges in building and maintaining friendships, and therefore will withdraw, prefer to just spend time alone, whether or not that's actually a preference or because of having, poor interactions in the past that didn't go well, avoiding social situations, being more withdrawn from others. Experiencing extreme discomfort in social settings with autism that can be related to the social interactions, masking all of that, but it also can be like a sensory component to or fear that there's going to be a sensory component. And then social skills difficulties as well. If there's anxiety that leads to, certain nervous behaviors, that can also lead to some challenges in having effective social skills. Like if you're so nervous about what you're going to say and how you're going to say it, then it makes sense that you're then going to have a hard time actually saying anything and engaging with others in a social context. But there are some of those differences in terms of like the physical symptoms of anxiety that look different for social anxiety versus autism. Cognitive distortions that, we know CBT is great for anxiety. There's definitely those components to consider for social anxiety, which look a little bit different for autism, because they're really more so just having a challenge understanding and processing those social interactions, versus having cognitive distortions about how the situation went or how they actually presented themselves. And then for the older youth getting into adulthood, there is quite a bit of overlap in autism spectrum disorders and schizophrenia. So we do have patients come in for evaluations where we're trying to tease this apart. And while schizophrenia is certainly not my area of expertise, we do have our uh, first episode clinic at University of Maryland, and they have a evaluation program. So they'll assess for the psychosis piece, and then will come to us and we'll assess for the autism piece. So the biggest things to consider, obviously, when we're diagnosing early in childhood, we're not really thinking it's schizophrenia. I mean, that's an easy way to tease it apart. However, when we're assessing in older adolescence, early adulthood, that's when it becomes more challenging. And one of the biggest pieces is really looking at, when did the symptoms start? Because if it was early in childhood, that's showing us that, it's more of a developmental piece that we see in autism versus a later onset. But across both, we would expect to see those social communication deficits, the negative symptoms, so the diminished emotional expressions, more of a flat, blunted affect. That's something that we see often in autistic individuals where they are just kind of flat, maybe even more of like robotic tone to their voice, not a lot of smiles, not a lot of changes in intonation. Impaired social cognition, executive functioning, language abilities, processing speed, all of these things that can be due to a variety of different presentations. Um, and then in terms of like teasing apart the positive symptoms of schizophrenia, like delusions and hallucinations, this can be hard because you can ask autistic kids and they're like, oh yeah, like I see things that aren't there. I hear things that when no one else is around, and having to really tease apart like, but is that like your internal like dialogue in your head? So sometimes like that concreteness, it can be really hard for them to understand like, oh no, that's just like me talking to myself. It's not like an outside voice that's talking to me, which can be hard to tease apart. Okay, and the last one is looking at some of the overlap and differences in autism spectrum disorder and borderline personality disorder. Um, here we may see an overlap in difficulties in theory of mind is a big one. So being able to put oneself in another person's shoes to understand what they're thinking and feeling in a situation. So this is a big one that we often see overlapping between both diagnoses. That emotional dysregulation, obviously for different reasons, but the presentation of it can be very similar. Impairments in social functioning and verbal and nonverbal communication, more superficial friendships. For autism, more so either less of a motivation to maintain friendships or just, struggling to do so. Can also see self-injurious behaviors across both. But, of course, for borderline personality disorder, there's more of that underlying self-image challenges, really trying to avoid abandonment, attachment components that are not present when we look at autism. We're seeing more of the restricted interest, the repetitive behaviors. The emotional dysregulation is more tied to unexpected changes and transitions and sensory components. So again, the symptom presentation can look very similar, but the reasons for them are very different. Okay, and then to wrap us up for the last few minutes here, I'll go a bit into some of the recommended referrals and interventions for autism. This is really the whole reason why we give the diagnosis in the first place is for a child to then have access to the services that they need. And sometimes this is a conversation that we have with families that struggle with their child receiving a diagnosis of autism and trying to look past that perceived label of autism and more so. But this is now opening the doors for your child to receive the services that are really going to be helpful for these different areas that brought you in to determine if your child has autism in the first place. Some of the most common interventions and referrals that I make following evaluations, of course, that big one is applied behavior analysis. The goal really to help increase a child's independence, whether that be in terms of self-care skills, communication skills, being able to, focus, to be able to learn new skills. I know there's a lot of, over the past several years, controversy about ABA. So really being mindful of what ABA should look like and consist of. We're not trying to get rid of or hide the autistic traits. If a child engages in hand flapping to, calm down when overstimulated, we don't want to take away a child's coping strategies to make them look more normal. What we want to do is build the skills for that child to be able to be as independent and happy in his life. So that is really where the ABA field has moved, and the goal of ABA, and obviously making sure when you make referrals that it's to a good ABA program. More traditional psychotherapy can be really helpful, especially for that level 1 autism, to address some of those co-occurring diagnoses. So, anxiety, social skills, if there's co-occurring depression, they can still benefit from like CBT and other related interventions for those co-occurring diagnoses, even like trauma therapy, if that's something that's co-occurring, even though I talked about the differences between the two. Autistic youth are also more susceptible to trauma as well. Social skills groups are a huge one, being able to learn skills, not just one-on-one in therapy, but in a setting with other peers that are going through similar experiences with someone there that creates a safe environment to then hopefully more easily generalize those skills to the real world. Occupational therapy is a big one. Oftentimes we think of occupational therapy like in school, fine motor skills, handwriting, but it's also really big on supporting sensory sensitivities, sensory seeking behaviors. When kids are feeling like overstimulated and overwhelmed, parents learn different strategies and techniques to either provide like deep pressure or trying out like weighted vests or weighted blankets to help ground them. But it can also help with the sensory sensitivities to like loud sounds and food textures and things like that, which is another one on here, feeding therapy to address sensory sensitivities regarding certain food textures. Sometimes kids are really rigid and brand specific on foods. They'll only eat a granola bar if it's a certain brand. And if you accidentally like broke it in half before you gave it to them, you might as well throw it away because it has to be presented the same way every time. So just anything around food and working on some of that flexibility too. Speech therapy, of course, is a huge one as well, not only for language delays or language disorders, but also for those pragmatic language skills. So, and making sure that the speech pathologists are well versed in working with autistic kids because oftentimes it's not an oral motor issue that is leading to speech delays, it's the social piece. If kids are not making eye contact, they're not socially motivated, they're not looking at others to learn how you move your mouth to make the sounds, to make the words, or understand that those around them are social beings, that when you communicate with them, that's how you get your needs met. So, really working on um, the language skills, you can't really tease them apart from the social communication skills because you have to start with the basics of getting the eye contact and things like that to build the language skills. And then the last one here is developmental pediatrics. I especially for younger children, well, even like school age kids, I'll often refer to developmental pediatrics, and explain to parents, it's kind of like a pediatrician in that it's more so an annual appointment, but they're going to really focus more on the development of your child, make sure they're still on track, be able to provide additional referrals if needed for like genetic testing. That is a recommendation for any child that receives a diagnosis of autism that they are referred for genetic testing. Of course, like the general pediatrician can also put those orders in, but just depending on who the family's seeing and what kind of additional services they have, developmental peds can just be a helpful addition to that and just kind of a check-in. They don't need a evaluation to confirm that they still have autism every year, but they can go to this appointment to just continue to track progress and make sure that they're making gains. All right, and then some of the financial benefits of receiving a medical diagnosis of autism, just really briefly want to highlight the difference between a medical and educational diagnosis of autism. Some schools will do assessments that then give a diagnosis of autism, well, or give a IEP coding of autism, but it is considered an educational diagnosis, and then insurance won't cover ABA for it. They won't qualify for SSI benefits. They have to get a medical diagnosis, and that's what can be provided through those qualified providers like the psychiatrists, psychologists, pediatricians, etc. Another thing to note is the autism waiver. This is for all kids under age 21. That either have an IEP or when they're younger, an IFSP through infants and toddlers. They provide a ton of different services, adult life planning, family consultation, respite care, therapeutic programs. The only problem is the wait list is ridiculously years long, but I still put it on every testing report where I give the diagnosis of autism because I have had numerous kids over the years get it. And even though they're on the wait list for a long time, it often comes in handy at that time when there's a gap in services. Now they're too old for ABA, but they're too young to go to some of these like vocational training programs. They still need additional support. So it has really come in handy for families when they do get off the wait list. There are also different grants for vocational rehabilitation services. The DOORS program is a big one to help autistic individuals get trained for various different jobs, help support them, find employment with employers that are equipped to work with autistic youth and be able to provide any kind of adaptive services or needs that they may have. And then Maryland DDA is another benefit for as long as they receive the referrals before the age of 22 and helps individuals live independently once they reach adulthood. Okay, I know we are out of time real quick. I just want to highlight this is a question that comes up a lot is the different types of psychological evaluations. Some of y'all have heard me talk about this before. There are three different types of psychological evaluations. Psychoeducational evals are what happens in school, so that leads to that educational diagnosis. Psychological evaluations is what we were talking about today. And then neuropsychological evaluations really focus more on brain function. So, memory, language, IQ, visual spatial, there's obviously overlap with psychological evaluations, but the biggest thing is there has to be a known medical, genetic, and developmental condition or brain dysfunction in order to qualify. So we have a lot of families call asking for neuropsychological evaluations, and it can get very confusing because they may or may not need it. But just to kind of highlight that difference, that there has to be a genetic disorder like a traumatic brain injury or a really sudden change in functioning for neuropsychological. So that's my last little caveat there. And that is it for me. Thank you guys. I can
Thank you so
stop
much, Dr. Gerard. That
sharing.
was great. The overlapping slide I found really helpful. So thank you for that. We
Great.
have a little bit slot time for questions. If you guys want to throw it in the chat, I'll try and put it together and get everyone's questions out there. I know we have a couple that privately sent me questions, so I'll bring those up. One question was for regarding Maryland Medicaid requirements, saying ABA referral in the last 6 months, does that mean within 6 months of documented diagnosis?
Not necessarily. We will often get requests following an evaluation. Um, where they need to like renew ABA services, basically submit, to get additional authorization. And then usually it's just a form to be like, yep, I diagnose autism on this date and yep, still got it. And so it's usually a pretty quick form that's like downloaded off of the Carillon website to fill out. Um, so even if like they get the evaluation and say they had to sit on a wait list for a while before they got into ABA, you may have someone reach out to fill out a really quick sheet and sign it, but it really doesn't take too long to do. You don't have to do like the whole thing again.
Okay. And then we have another question. If a patient would benefit with an alternative communication device, is that a referral to speech therapy or another referral source?
Um, Speech therapy will often be the best referral to help support in training a child to use those different devices. So whether it be like using the iPad, text to talk, or the more old-fashioned PEX system with the Velcro, that is often supported through speech therapy. ABA, though, teaches that as well. So there is overlap between ABA therapy will do like a little bit of speech, a little bit of OT, and then the additional behavioral pieces, which is honestly really nice because something that happens with autistic kids is if it's like the same person presenting and teaching in the same way, then they only learn to respond that one way. So the more providers are presenting things in different ways, the easier it is for a child to generalize across different contexts.
And we have another one here. For many of the most impaired level 3 autism spectrum disorder diagnoses, they may also have intellectual disability or nonverbal. How can you determine if ASD-like symptoms are actually secondary to a global developmental delay or intellectual disability? And if you could provide maybe an example or two.
Yeah. So it does come up quite a bit to determine is it just ID, is it just autism, or is it both? The biggest difference is the presence of the restricted interests and repetitive behaviors with the cognitive deficits through like low IQ, low adaptive skills. So that's really a big way to tease it apart. When they overlap and it's both, I would say usually I'm seeing like especially in school-age children, adolescents, if they have an intellectual disability, we're looking at autism level 3, maybe autism level 2. And I say that that's almost always the case. And then there are a few times that that hasn't been the case. Um, and I've given a level 1 autism with an intellectual developmental disorder. And in the reason I do in those situations is because they are meeting the diagnostic criteria for autism, but that's not where they are most impacted. Like, yes, there are some RRBs, there are those social communication deficits, but what's really impacting them is their cognitive functioning is so low, and their adaptive skills are really impacted. So there are certain situations where that happens, but I would say most often they kind of go together in terms of the level 3 and the ID.
Gotcha. And then, can you provide strategies for resolving conflicting data, such as when the parent report is completely the opposite of a teacher report?
Ah, I love when that happens. It happens a lot. So one thing is if uh, say the parent comes in, reports all of these signs of autism, the teacher corroborates it, and then the parent is giving nothing on the parent forms, but we're also seeing all the autism. I give the autism diagnosis and then I talk through it and explain why I'm giving it. And like, are you seeing these behaviors as well at home? Oh, yeah, yeah, okay. So sometimes it could just be they weren't paying attention when they completed the forms. Maybe as the evaluation's getting closer, now they're, uh, kind of struggling to really report and see all of the symptoms that brought them in. Sometimes we'll see across the board, background information. This kid's great. There's nothing going on. Parent report, everything's fine. Teacher report, through the roof. We're seeing all the signs of autism. Again, I'll give the diagnosis in those situations. We'll talk about it. And oftentimes, the conversation is more about, what are your concerns? What are your fears for your child? And because they may be mourning the loss of a typically developing child and not quite ready to embrace the fact that their child's receiving this diagnosis of autism. And then we'll kind of put, well, let's put the diagnosis aside here. And, we're seeing some of these delays in language and, we noticed he wasn't giving eye contact, or, when we were calling his name and he wasn't looking up. These are the services that are going to help with it, regardless of what we call it. And so, not to say that I say all of that to say I do think that parents know their children best, but sometimes they're just not in a place to be ready to report all of those symptoms. So in those cases, we want to make sure that they're not missing out on, especially when they're really little, the opportunities for early intervention, and kind of help guide parents to get to a place where they're ready to at least accept the services, even if they're not quite ready to accept the diagnosis yet. But what's really helpful is if what can be really hard is when parents come in and they don't know why they're there for an evaluation and they seem shocked that autism is even something that's being questioned. So just it's okay to say the A word and bring it up to families. The more they hear it, the more likely and sooner they're going to be ready to embrace the services that come along with it.
Great, thank you. We have just about 5 minutes, so I'm gonna give maybe three more questions. There's a question about noting the controversy of ABA. Do you still recommend ABA? And then kind of a little bit more context, the concerns that families have that children being diagnosed with autism due to fears of them ending up on a federal list. Is that concerns affecting your ability to diagnose and treat? Um,
Great questions. One is I do still recommend ABA. I agree that the way that ABA, so I'm a BCBA as well. I used to do ABA in grad school. I would say looking back, it was not the best way of doing ABA. It was more discrete trial training, trying to address the symptoms of autism versus really being more focusing on building the skills, which was a piece of it, but the field has come a long way. And just, telling families to be mindful of what the purpose of ABA is and making sure that, the providers that they're going to are using more naturalistic environment, for example, instead of like more rote, like holding up two cards, a red and a blue, touch red, touch blue, 50 times in a row. It's more so like, oh, we're coloring. Oh, you want the blue crayon, like make it more natural in the play and the activities that they're doing, to teach them to be more independent because they're going to learn to label the colors versus making it so robotic. The other thing, I'm surprised I haven't gotten more questions about being on like a national list, if they receive the diagnosis of autism. But it's something that I've definitely thought about. Um, so one thing that, has been sort of discussed is, reviewing Medicaid records for diagnoses of autism, then being able to look through and see, like, did their parents take certain medications during pregnancy that then led to autism. But what's interesting is in behavioral health, we can never bill for a diagnosis of autism. So their billing records that we know when they say they're going to review Medicaid would actually never have a diagnosis of autism on it because we can't actually officially bill for it. So they would have a very hard time finding our records. Not foolproof, but it certainly helps in that regard.
All right, two more questions. So we have a question about AUDHD. If you can comment a little bit about that, what really is
Yeah, that's autism and ADHD when a child presents with both of those. And they are very commonly co-occurring because they're both neurodevelopmental disorders. We see a ton of overlap between the two. So that's another piece of really trying to, tease them apart in the situations where they one diagnosis better fits than having both of them. But it is very common to have both the inattention, the hyperactivity, as well as the additional symptoms of autism, the sensory, the RRBs, and social communication challenges.
right? And then last one, it's touching on the diagnosis of autism and borderline personality disorder in a child. Since we don't diagnose children with borderline personality disorder, have many of the criteria, but they may have criteria of borderline personality disorder due to the overlap. Should we be thinking more about screening for more of these girls for autism spectrum disorder? This was seen clinically.
Yes, I would always recommend more screening and looking at all of the different possibilities. I mean, a big one here too is like family history of either or, and kind of seeing how that some of those genetic predispositions may play a role as a child gets older, and then may be more appropriate to diagnose with borderline personality disorder, but. If we're seeing the symptoms earlier on and they have the developmental history, I would definitely be leaning more towards the autism side versus it being that borderline presentation. And also look at trauma.
All right. I think that's all the time we have. I think right on dot 8:15. So
Look at that.
yeah. Any last comments, Dr. Gerard, or
No, thank you all so much for having me and having such great questions. I appreciate it.
great. Thank you so much again. Appreciate everyone that joined. This should be recorded and posted. I'm going to find out from Francis as far as the details of that, and then everyone should be getting an email with the CME link. And just to wrap up, a reminder that the second part of this lecture is going to be March 26th at 7 p.m. If you haven't registered, you can register online or with LinkedIn. You should have a link from this lecture as well. So just keep an eye out on that. And it's going to be two lecturers, Dr. Inges and Dr. Register Brown. who are going to touch a little bit more, expanding on this series.